Welcome everyone to the National Foundation of Swallowing Disorder webinar series. My name is Ed Stever. I'm the president of the foundation and also a head and neck cancer survivor. Our mission as a foundation is to improve the lives of those with a swallowing disorder in our lifetime. And we do that through 4 pillars: providing direct patient support, offering educational opportunities such as this webinar, raising swallowing disorder awareness, and promoting promising research. A few housekeeping items. You will be muted during the presentation, and to ask a question, click on the blue question mark to type in your question at any time. Dr. Kuhn has made time in the middle of her presentation and at the end to address questions. She has also provided 3 handouts which are available for download from the toolbar that you should have on the device that you're using. Why don't we go to the, the webinar is being recorded. I just want to get that out there, but it's being recorded so that we can put this up for those who couldn't make this actual event. I'd like to talk about things that we're doing that are new for us. And one of them is a virtual real-time swallowing support group. We had our second session last week. It's led by a licensed psychologist and that person happens to be Sonia Blue, who is the co-founder of the foundation in 2006. And she partnered with Elizabeth Lipton, the foundation's executive director, and also a speech language pathologist. In the last session, there were 7 participants, and their maladies included head and neck cancer, base and tongue cancer, an accident victim, someone with a neurologic disease. So it's a wide range of folks that are participating, and the feedback was very positive. One person actually wanted to meet weekly, others monthly, others quarterly. So we're kind of working through the timing. The other thing in line with this is we're getting ready to launch a support group for caregivers who are taking care of children and the pediatric population. So if you're out there, either as a patient or a caregiver or an SLP who knows someone who might benefit from participating in a support group, please email us at info@nfosd.com, and we'll get you into the support group. Now, I'm going to change subjects here, but the next slide is out of our swallowing disorder lane. But I'm presenting it, and it reflects my views and that of our foundation board members. We support the Black Lives Matter movement and addressing income inequality in America. And we're supporting these causes with more than just thoughts and prayers. We're in the process of diversifying our board in the hope of bringing a wider range of cultural views and voices to our mission. We are also in the process of reviewing and revising our mission statement to align it to current thinking. And lastly, this is important. In our post-webinar survey, we've added a question asking you what else we can do to align ourselves with these movements. We want to hear from you. Now, in light of this, I'm highlighting 3 areas. First, if you're not registered to vote and you're in the US, register to vote. Second, vote as early as you can in the jurisdiction that you fall in. And third, if you know someone who isn't registered or could use help becoming registered, help them register, help them vote. And do this as if your future depended on it, because it does. This webinar was made free of charge thanks to an unrestricted educational grant provided by our largest term sponsor, Bracco Diagnostics. And that allows us to pay for our webinar license and the time of organizing the event. We deeply appreciate Bracco Diagnostics' support. As a nonprofit organization, we rely on the generous financial support of our corporate sponsors and donors like yourself. Many of you provided a donation to in support of joining tonight's webinar. We deeply appreciate that. We would like to recognize our annual sponsor, MedCoat USA. MedCoat has created an innovative product designed to cover medications in a flavored, slippery coating to facilitate swallowing. Following tonight's webinar, in the post-webinar survey email, you will receive a link to request a free sample should you be interested. And I want to add that the foundation had the honor of being at the Advanced Practices in Voice and Dysphagia Conference in Las Vegas, BP, before the pandemic. That was in late February. we had samples of the Medcoat product, and people were blown away by it. We ran out of the samples, and people wanted to know where to get more. I think if you see it, you try it. I was impressed. I think you will be impressed as well. It's my pleasure to introduce tonight's keynote speaker, Dr. Maggie Kuhn. Maggie is a leading laryngologist and bronchial, I'm not going to be able to say it, bronchial esophagologist at the UC Davis Center for Voice and Swallowing. I just think of Maggie as a rock star in her field, so that's easier for me to say. Maggie has a special interest in understanding pill dysphagia and recently co-authored the first patient-reported outcome measure for pill dysphagia. As a head and neck cancer survivor, I appreciate all the work Maggie is doing to develop novel treatment options for those suffering from a swallowing disorder. And at this time, I will turn it over to Dr. Kuhn, who has volunteered her time tonight to share her knowledge with us. Thank you, Maggie.
Thank you, Ed. That introduction was much too kind. And likewise, I feel as though I'm in the presence of a rock star with you. And thank you also to Elizabeth for helping with the logistical aspect of getting this going, and for the invitation. I do appreciate the timeliness of this topic, and am thrilled that tonight's webinar could be sponsored by Medcoat. I was one of the few lucky attendees to get a sample in Las Vegas, and agree that not only was the product effective, but very easy to use. And we'll talk a little bit about some of the products that are available out there to help in our quest to ease some of the symptoms of pill dysphagia. Tonight, I'd really like to drive home the message and really the call for us all, coming from international locations and from certainly varied backgrounds, but all with a concern and a passion for swallowing disorders, to really care about issues surrounding the appropriate and efficient administration of medication, because I will hopefully convince you at the end of the next 45 minutes or 1 hour that we could be doing better in this arena. I just wanted to add that I don't have any important disclosures to add. I may be mentioning a few off-label uses of medications and products, but have no financial interest in any of those. So what's fascinating to me about difficulty swallowing pills is that from as early as 200 years ago, at least in the United States, difficulty swallowing pills has been associated with negative experiences. First published in a New England newspaper in the 1820s, a hard pill to swallow was in print, describing a difficult situation in a New England town with some sort of judgment on a convict in that town. And certainly throughout history, famous individuals have referred to challenges or unpleasant situations, adversity which must be overcome, as a hard pill to swallow or a tough pill to swallow or perhaps a bitter pill. And so for these, yes?
I'm sorry to interrupt you. Your slides, we only see a blank screen, and I think it might have to do with presenter mode versus presentation mode.
Oh dear, thank you.
Before you get into your presentation, I was just going to see if we could pull up your slides here. There we go. Now I can see them. And if you click full screen, I think we should be able to see them.
Tell me if is that working?
Let's see, we can still see the slides on the side and the screen.
Okay, hang on. I do see now where you can see what I see. Let me try. Apologies.
No worries.
Interesting. Hang on. I have some thoughts. Oops.
I think if that doesn't work, we could always just make the screen bigger so that we hide the stuff on the side. Or I'm happy to pull up the slides that you shared with me and present from my end, and then you speak and just let me know when to flip the slides. Up to you.
Sure. Interesting. I'm sure it has something to do with the display. I'm sure. Okay.
Strange that when you press that button, it doesn't go to.
Right.
Yeah, it's probably the same if you hit play from start, I would imagine too. Yeah, that's strange.
Okay, let me try one more thing.
And for those of you that are just signing in, I was just going to let you know we're just working on bringing the slides up to full screen here, and we'll get going in just a second.
All right, Elizabeth, why I have animations and things, so I don't think it's going to work very well for me to play it in this configuration. So
So do you want me to play it from my screen? I'm not sure. I have the compressed version. I don't know if that has the animation.
shoot,
Yeah.
no, sorry. Oh man, why it's weird because it was working before.
That is strange.
Maggie, why don't you close out and then bring it back up?
That's a good idea. And actually, I think if it's okay, Elizabeth. Oh, actually, here, let me see if this helps. I'm also getting messages that people are trying to get in, but it's reached its limit.
Yes, yeah. I'll take care of that part here. Somebody said if you press F5, sometimes that.
Ooh, yay!
There
That
we go.
works, right?
Yep, I think we're good. Yes. Awesome.
All
Thank
right.
you everyone for your patience. I appreciate it. All right, take it away, Maggie.
Okay. Oh, do not show again. There we go. That will help. All right. Well, thank you all for joining us, and see you next time. No, just kidding. So as I was saying, it's really quite amazing that throughout really the lifespan of modern America over the past 2 centuries, we've associated with pill swallowing as being a difficult task, and I think we'd agree today that it continues to be as such. Though clinically somewhat under recognized. And certainly even this issue of difficulty taking medication orally has made its way into popular culture, as seen here from a clip of the Family Guy.
Okay, look, tempers is starting to get a little heated, so why don't we all go take us a little potty break?
Now you're all going to have to witness me taking an old man pill that looks way too big to swallow. Oh, there we go.
Right, and only really funny and humorous because I think we can all relate to that. There's really some truth there. So pill dysphagia, what is it? Well, it's dysphagia. It's the symptom of difficulty swallowing a pill, and that can manifest in a variety of ways, right? A pill that gets stuck, a pill that's regurgitated, a pill that feels like it hasn't passed, or that's dissolving, a painful pill swallowing experience, or even an aversion to swallowing pills. And as I mentioned, although known and familiar to all of us, in a clinical capacity, it really remains under-recognized and underappreciated, even though it's reported to occur in almost half of all adults. And in early childhood, it's pervasive. Every child up until starting around the age of 6 to 7 has pill dysphagia. And why is that? Well, it's because swallowing pills challenges normal deglutition, normal swallowing physiology. We basically skip preparatory and oral phases and are asked to swallow something without modifying it all in our mouth, and it really does fly in the face of what we're born with in terms of our innate swallowing skills. And what's unique about pill dysphagia is that it often is present without any coexisting dysphagia to liquids or solids. Though, of course, individuals with swallowing impairment are often afflicted with difficulty swallowing oral medications as well. And this is particularly germane to contemporary America. And I recognize that we have a nice audience of international listeners, and I don't have international figures, but I think that this is a universal theme that we can all relate to. Although we are one of the largest consumers of medications in the world, over 45% of global pharmaceuticals are consumed here in America. These numbers are really staggering. Over 60% of adults take at least one medication, and this number significantly increases with an individual's age, with an average of 3 medications taken by individuals over the age of 50 and 8 medications on average taken by individuals over the age of 75 years. And if we think about the rates of swallowing impairment of individuals in that decade of life soaring over 15% in the general population and close to 45 or 50% in nursing homes, the difficulty there with the number of pills that an individual must take in order to be compliant becomes blatantly obvious. And over 90% of the prescriptions that we're talking about are prescribed to be taken by the oral route and often in a solid form. I think we would be a bit remiss to have a conversation about pill dysphagia without thinking at least surface deep about the pharmacology of medication. And I think from a pharmacist point of view, drug delivery is all about bioavailability. And what is that? Well, bioavailability is really the proportion of a medication or a drug that reaches the systemic circulation. And ultimately, most medications do reach the systemic circulation, even though the route of getting there may differ among medications. And the bioavailability of any given drug is influenced by that route and also by the medication's formulation. So what do we mean when we say the route? Well, the route is the means at which the medication gets from the world into the circulatory system. And broadly speaking, there are 2 routes. There's enteral, which you can think of as entering through the gastrointestinal tract, and parenteral, which is outside the gastrointestinal tract. And so medications which are taken orally are is an enteral route. Now, most medications that are taken orally are swallowed, but also formulations that are meant to be mucosally absorbed in either the sublingual space that is under the tongue or in the buccal space by the cheek can also be taken by the oral route, but those are not absorbed in the intestine into the circulation, but rather into the very richly vascularized tissue of the oral mucosa. And the other major route for for enteral medications is parectal. Now, what's interesting is most of us are probably pretty familiar in managing tube feedings and having patients that depend on feeding tubes. But a feeding tube actually isn't classically considered an enteral route, and most medications don't have specific indications to be given by feeding tube. By the feeding tube route, which you could imagine creates a big problem when patients with dysphagia who are dependent on feeding tubes need to be given their medication by that route as well. Parenteral routes include routes that are directly into the circulation, such as intravenous, as well as other injectable routes, intramuscular, subcutaneous, as well as inhalation, dermal, and other types of mucosal access, such as the eyes or the nasal mucosa. When we talk about medication bioavailability, the other major factor that influences bioavailability is the formulation of the medication. And so through an enteral route, there are several different formulations which a pharmaceutical company can create, with over 75% of medications given enterally being in a pill formulation. And pills can take the shape of tablets or capsules. Other formulations include liquids or solubles, and that would be powders, dissolvable tablets that may dissolve in the mouth, chewable tablets, granules, and films that would dissolve in the mouth. Again, over 75% of enteral medications are manufactured as pills, meant to be swallowed. And pills have certain features which also can influence their bioavailability and incidentally can influence how easy or difficult they might be to swallow. Pills may be coated or uncoated. Coated pills may have a special coating called an enteric coating, which protects them from any sort of degradation in the stomach so that they're completely degraded and absorbed in the intestines. Some tablets have scoring, which is usually meant in order to divide a medication's dosage easily. The size of a pill often has to do with the strength or the composition of the pill. In general, capsules tend to be larger than tablets in order to contain all the small components of the capsule. And shape can vary, especially among tablets. Capsules tend to be a cylindrical oblong shape, whereas tablets really come in a variety of shape, and much of that is really related to marketing. So why are pills so common? How did that come to be that what we are most frequently faced with are pills, our solid oral formulations? Well, probably most importantly is that pills are economical. In order to mass produce medication, it's least expensive to make pills. If they're swallowed directly, they don't require any special flavoring. And without being a chemist, my understanding is that the chemistry and the biomechanics of the composition of a medication to be in pill format are much less labor intensive to create, require less resources, and less manipulation, less steps in order to be shelf stable. Plus, less packaging and materials are needed in order to create and market bottles of pills. Also, pills are convenient. They can be self-administered. They're highly transportable, and as I mentioned, they're shelf stable. Most pills not requiring any sort of refrigeration. And compared to other routes of administration, such as injectable or per rectal medications, taking pills by mouth is reasonably hygienic. Also, there's a good confidence in the dosing accuracy of a single pill. Now, that's not to say that the predicted bioavailability of the medication is ensured, because of course that is influenced by other characteristics of the patient taking the medication. But as the pill comes out of the container, the dosage can be fairly ensured. And there's some flexibility in dosing too. These pills can be taken multiple times a day, divided doses, and the like, without much difficulty. Just to keep things a little interesting and to prevent you from getting bored with my voice through this presentation, and to underscore how commonplace this issue is, that there's actually a second episode of the Family Guy that refers to this problem, I thought it would be worthwhile sharing another clip with you all.
Okay, Brian, so we like the same girl. There's no reason we can't be gentlemen about this.
Absolutely. Our friendship is more important than any one girl.
Hey guys, I got us all some food.
Oh, great. Just mash Ryan's pill in there and smear it on the grass. He's good to go.
Oh, no, he's kidding. I'm perfectly capable of taking a pill.
Yep, down the hatch.
Again, funny because it's true, and I particularly like that clip because it reminds me to mention how much larger the pill accessory market is. So gels and coatings and disguises for pills is in veterinary medicine than it is in human medicine. We've done a really good job for decades at disguising medication for our animals, more so than facilitating the administration of oral medications for each other. So why does pill dysphagia develop? How does this happen? Well, it turns out that there are often patient factors, and most of these are commonplace to the swallowing disorders that we may encounter all the time, related to myriad comorbidities and etiologies for swallowing impairments, such as motory dysfunction, sensory impairment, changes to the milieu of the pharyngoesophageal structure, including xerostomia, certainly anatomic variants, whether congenital or post-surgical, variety of dysmotilities, in particular esophageal dysmotility, or any sites of anatomic obstruction, whether acquired or iatrogenic. And then oftentimes, pill dysphagia exists, as I mentioned before, in the absence of liquid or solid dysphagia. And whether this is a form of phagophobia, I think could be argued, but it may just simply be, as stated before, that there's not much natural about swallowing a pill whole. And then there are pill factors which contribute to the entity of pill dysphagia. So what is it about certain pills that makes them really tough to swallow? Well, pills that are larger are going to be more difficult than pills that are small. It's instinctive to reduce the size of firm objects, boluses in our mouth, to something smaller and more manageable. We know that tablets, which tend to have a higher degree of friction on the coating, are harder than capsules, which tend to be in a gel outer covering and tend to slip a little bit more easily. And then of tablets, uncoated tablets tend to be more difficult than coated tablets. And then of the tablets as well, those that have an oblong shape, which also incidentally happen to be large, are more difficult than round ones. So these certain characteristics of the pills make it difficult. And then most of us are taught to swallow pills in some sort of liquid, usually water. And so that is a mixed consistency swallowing task, which can be challenging, especially if our mind is believing that we're trying to swallow a foreign body whole. And then there are certainly poor pill taking hygiene and bad habits that can develop over time, particularly as we age and the number of pills that we have to take on a daily basis increases. So not having sufficient water to wash down pills can cause bad experiences, or pills getting stuck, which can lead to further aversion, or taking a handful of pills at once, which might work initially, may start to be more challenging, and that can generate symptoms of pill dysphagia, as well as anxiety and fear surrounding the tasks. And the consequences of this are really not trivial. And so we may say that we have a bitter pill or a tough pill to swallow, as an idiomatic expression in our language, but in reality, the issue with pill dysphagia can be quite significant and have major implications for patients, including issues surrounding misdosage of medication, including poor adherence, inadequate therapy because pills are not being taken, or adverse reactions or overdoses of medications because they're being modified or compounded inappropriately when they're difficult to swallow. And in the presence of real swallowing impairments surrounding pills, errant pills, pills gone astray can cause issues too. Retention, just like a foreign body, caustic or erosive injury to mucosal surfaces, most commonly in the esophagus, pill esophagitis, choking or aspiration if the medication ends up in the airway, and of course the mental stressors and anxiety surrounding these experiences. I wanted to take some questions here since we were a little bit delayed in starting because of technical issues. I wonder if maybe we should just move on. I don't know, Elizabeth, if you're seeing a lot of questions.
Yeah, I have two questions. I think one here will be fairly quick. The first question, can effervescent tablets be given through enteral means?
Absolutely.
All right, and then the other question is, which healthcare professional might be best to identify adjustments needed for oral medications taken through a feeding tube? So a physician or a pharmacist or other specialist?
That's a wonderful question, and I think, and I'm going to highlight that in the second half too, is the answer is we don't know, or it's not clear, and I think that is part of the reason why we're not serving our patients as well as we could, because it's not clearly defined whose responsibility this is. I do have some resources toward the end to help with decision making when it comes to using medications in feeding tubes. I'll be honest, it's a little unclear who those resources were made for. I like to believe it's for pharmacists, but some of the literature would have us believe differently, that it actually is for prescribers. So great question.
I'll ask one more and then I'll let you continue here. The next question, is there a difference on the bioavailability of crushed pills versus whole pills?
Yes, and actually one of the references which Ed mentioned are available for download is a paper out of Europe that talks about making modifications to pills, particularly in the elderly. And there's some really good graphs in that paper that demonstrate what the bioavailability of a crush pill, of a certain crush pill, may be compared to a pill that's left intact. I think the important, so yes, they can differ. And what's also important to know is no two pills are the same. So no two medications are going to be the same in that regard. So crushing or grinding one pill may have no effect on the bioavailability, where it could have a significant effect on a different medication that even looks very similar, which is why I would argue that it's really the pharmacist's job to be the savant here and educate the rest of us, and most importantly, patients around appropriate behaviors there.
Perfect. Thanks so much.
Cool. All right, so moving on to some evaluation and management of pill dysphagia. I think if I'm going to say that pill dysphagia is underappreciated and under-recognized, I'm going to follow that right up with we need to do a better job of screening and identifying our at-risk patients and making sure that those patients and their caregivers are aware of that risk and are advocating for themselves. Patients with pill dysphagia likely deserve an appropriate swallow evaluation, and I think this should follow a typical algorithm that any swallow expert would apply to their patient, but patient with pill dysphagia is no different. And appropriate management really should engage the entire care team. So from the prescriber, the individual who's recommended a certain kind of medication, to the pharmacist, and then of course to the swallowing team if involved. The medication list should be optimized to really include the medications, that are absolutely necessary in the most appropriate formulation available. And the pharmacist, the provider really should work with the pharmacist in cases where an appropriate formulation isn't readily, seemingly available to identify an alternative. And then when an alternative formulation isn't available, then perhaps it's appropriate to employ modifications to the medication which must be taken, or use adjuncts, and I'll talk about that in just a minute. And then we know some strategies to teach our patients, both cognitive and behavioral, to assist in the effort of taking their daily medications. And so, as I said, this should be a multidisciplinary approach. Pharmacists are not doing a great job of this, at least in the United States. There are some promising work out of Europe suggesting that at least there's a call for better screening at the level of the pharmacy. And I think there isn't great evidence of whether it's happening, but anecdotally, this does not happen well in the United States, screening for pill swallowing issues. When an at-risk patient is identified, alternative formulations, or being directed to a compound pharmacy where there's a qualified pharmacist to compound medications into different formulations, should be recommended. And then if neither is available, patients and their caregivers should be educated by pharmacists on the safety and efficacy of pills which have been modified. And again, important for pharmacists to engage with prescribers to make sure that the medication list is as lean as possible and things are tailored in the right formulation as closely to the needs of the patient as possible. What we tend to see, at least in the United States, is pharmacists communicating a lot by these labels instead of actually educating patients. And don't get me wrong, I think that these are important and they are probably avoiding some bad outcomes, but I don't think labels that are just instructing patients to swallow whole, to not crush, to not chew, to take with food or milk, are necessarily granular enough in order to really be effective, for an individual with unique swallowing issues. And I think at least here in the United States, there's a bit of warning label fatigue, and whether or not these are actually being followed isn't clear, and whether or not they're all accurate also remains to be determined. And I really don't, even though it may seem this way, I really have no intention of criticizing the practice of pharmacology. I don't know enough about it to speak expertly on it, but I think there, I'm coming from a different interest, right, in managing my patients who are going to struggle with swallowing medications, whereas pharmacists are really more interested in the biomechanics and the pharmaceutical properties of the medications they're prescribing. And in a very unscientific look into what a pharmacist curriculum might be and might contain vis-a-vis swallowing impairment and how to overcome that for patients that need to take medication orally, I scanned the top 5 pharmacy textbooks as well as the online curricula pages of the top 5 pharmacy schools in the United States and searched the table of contents and word search for dysphagia. Again, not scientific, just curious. Dysphagia came up 0 times. And I searched for swallowing, which came up once in one of the textbooks in reference to an adverse drug reaction from a medication causing swallowing impairment. So not saying this is wrong by any means, I just think the interest is different, the focus is different, and this may be a gap that needs to be overcome if we hope to do better by our patients. And I included this figure in here, pulled from one of these textbooks because I thought it illustrated the point well, the steps of the drug cycle. And I like how here, this medication taken orally, it starts at the lower esophageal sphincter. Like, forget about the lips and the mouth and the esophagus. Like that just happens, right? There's no actual physiology there. So again, not wrong, just a different way of thinking. You know, the how it gets there is, you know, less important, even though, you know, I'm building a career out of that. So then us, I'm assuming the majority of us in some fashion are deglutologists. If we're speech language pathologists, if we're a physician, we're a radiologist who performs swallowing fluoroscopy, we're a dietitian, we're a caregiver for our loved ones with swallowing impairments, or we have a swallowing impairment ourselves. We are amateur deglutologists or expert deglutologists. And it really is our job to screen for pill dysphagia, particularly in our patients with coexisting dysphagia, and to choose the appropriate assessment for that impairment. And based on the findings of that assessment, provide patient-directed therapies. And then to communicate with prescribers and the pharmacists to make sure that we're optimizing the formulation of the medications that the patient is being given. And I think we play an important role as well when we follow up with these patients to monitor their adherence to their medication and make sure that we couldn't be doing better. So, assessment of pill dysphagia. Let's start with patient self-reported symptoms of their swallowing problem. And when it comes to reporting issues on any one of the multitude of patient-reported outcome measures related to swallowing, a minority actually inquire about pill dysphagia. I highlighted the EAT 10 there because of the 10 questions. One question on there is about swallowing pills, about choking on pills specifically. These other instruments do not include questions about pill dysphagia. And I'm not really passing judgment or a critique, making a critique. I'm not sure that that's necessarily the right place for questions about pill dysphagia, as we have really already discussed that pill dysphagia is so unique and it can really occur in the absence of liquid and solid food dysphagia, that maybe it doesn't belong in one of these instruments that we know well. And to that end, our group decided to look at constructing a novel symptom index in order to qualify patients' degree of symptomatology surrounding swallowing oral medications. So in an effort to make an approachable, useful instrument through an iterative process, this 5-question Likert rated instrument was developed, and it was given to nearly 200 patients and 200 healthy volunteers in order to assess and establish validity. And by measuring a patient's esophageal transit time of a barium tablet during esophagram, we're able to establish really good construct and criterion validity with this instrument. That is to say that patients with high scores indicating higher level of symptomatology from pill dysphagia had longer esophageal transit time, and those with lower scores had shorter esophageal transit time. this was repeated among the patients and there was good reproducibility. In normal individuals, the mean score on this instrument, which is out of a total of 20, was 1.6. And a score of greater than 6 was determined to be abnormal, as this is exceeding over 2 standard deviations from the mean of the normal cohort. So I hope this will be a useful tool moving forward to
Call from 12155725238.
Sorry. In order to monitor symptoms related to pill dysphagia as modifications are made, screen for pill dysphagia, and certainly to be used for research purposes. The clinical evaluation may not be the best purview to evaluate for pill dysphagia, though certainly a thorough history is really informative. But the reason I brought it up is because I really wanted to make mention of the functional oral intake scale and propose that maybe this is also a good place to indicate a patient's ability to swallow oral medications, and perhaps there should be a little subscript along with the the 1 to 7 or the 1 to 7 score for how they do with their diet that indicates how they're managing oral medications, particularly for patients with feeding tubes. But I think probably more germane to take some time to talk about using instrumental assessments for pill dysphagia. And really the standard tools for this particular entity would be endoscopic swallowing evaluations. So of course fees, but I would propose that endoscopic evaluation of the esophagus or guided observation of swallowing in the esophagus, or GOOSE, is a particularly handy tool to use in this population. I'll show you something in just a moment. And of course, swallowing fluoroscopy is an excellent tool to evaluate for causes of symptom of pill dysphagia. And here's this substernal pill here on this AP view. So this isn't my picture. This is from a leader paper published a couple years ago. And it demonstrates actually evaluating for efficiency of pill swallowing during fees, which I think is a fantastic idea and really is an extension of what many of us already do, which is try to reproduce patients' symptoms by having them bring in items that give them trouble to actually administer during fees, and it's a great opportunity to give pills as well. We do take that one step farther in our clinic. If we don't see any pharyngeal sites of swallowing impairment when it comes to pills, we'll often follow the pill then into the esophagus. And here we see a retained tablet in the mid esophagus and at high risk of causing a contact ulcer or pill esophagitis. And so not only can the esophagoscopy identify sites of pill transit impairment, but also sequela from that delayed transit, such as esophagitis or ulcerations. And I just want to take a second and put up the usual suspects in terms of culprits that are commonly associated with pill esophagitis. It really, if you remember that top row, you're in good shape. The doxycycline, potassium chloride, and aspirin are probably the 3 most common agents to cause an issue, in mucosal injury to the esophagus, with iron being another one as well. And then fluoroscopy as a tool in assessing pill dysphagia is a very useful one, especially if you use barium-filled capsules or barium tablets. We like in our center to use a 13-millimeter barium tablet. And for this individual, I think it was really important to recapitulate her symptoms by finding the pill, or the tablet rather, sticking at the pharyngoesophageal segment, to then, direct our investigation and take a really close look at what might be going on in that area. And it's actually a fairly subtle web, which we see in that pharyngoesophageal segment that we may not have thought to be consequential otherwise, but that could easily be dilated with that finding. And here's just one more example of an individual with pill dysphagia. It's a little hard to see. This ring is actually around the patient's finger, and so they're being asked to point where they feel the pill sticking. And so they feel it up in the sternum, up at the manubrium there, but in reality here, the pill is down at the distal esophagus. And when the distal esophagus, the gastroesophageal junction, becomes full of barium, we see that there's an obstructing Schatzki's B ring right here associated with the hiatal hernia, causing the pill stasis in the distal esophagus. And you can sort of make out here at the gastroesophageal junction where that narrowing is, and you'll see it even better when we inflate a balloon in there. And this is something that, if it's causing symptoms, can very easily be dilated and disrupted. And this case gives me an opportunity to quickly mention the importance of esophageal screen, which I don't think would be disputed among many of the audience here, but I listed two papers that you can look up that really advocate not only for the use of esophageal screen, but for a tab or a capsule in the esophageal screen, as it increases the sensitivity of detecting abnormalities in the esophageal phase rather than just a barium follow through. So beyond some of those fun dilations, what else can be done for these individuals with symptomatic pill dysphagia? Well, we've talked quite a bit actually about pill modifications, and this really should be done with guidance. And I have those resources on the next slide. Really, in my opinion, that guidance should come from a pharmacist who understands really the bioavailability and the pharmacokinetic properties of the medications. But I will say that most capsules can be opened without a problem and put into a liquid or into any other food substance in order and be taken. Tablets can sometimes be chewed instead of swallowed. Very few are actually made with flavoring, so this is usually an unpalatable option. But for certain medications, this can change the properties of it. So again, it should be discussed with the pharmacist. Most pills can be cut without a problem. There are enteric coated medications where once cut won't have that enteric coating on that cut surface of the pill, and because the pill can sit in the stomach for up to an hour or so, significant degradation of the medication can happen. So pill cutting is a good option, except for those that are enteric coated. And then crushing and grinding are effective at making, fine powders. But again, this should really be done under close guidance. There's also a medical legal issue which comes up with modifying medications really in the absence of medical advice. And it comes up often in situations where patients are cared for either by a visiting nurse or at a nursing home and making modifications to the pills. And some have argued that if a patient, if a caregiver is going to do that, the patient needs to give consent to take a pill in that variety. It can create some difficulty because often such patients are needing that care because they have dementia and don't have capacity to give consent. So both the United Kingdom and Australia have done a fantastic job of collecting information surrounding nearly every available medication with their different available formulations, and their safety to be given via feeding tube into these two handbooks, and the websites are listed there. Both are available to be purchased, and both have online editions as well. And then this Institute for Safe Medication Practices is a global non-profit organization that actually has a really nice database, I guess you will, of different medications and ones in particular that shouldn't be modified, in particular shouldn't be crushed. And this is available free at that website and may be a good reference. And then there's the orchestration, really, of how pills are taken. And this is arguably much less risky, much less dangerous, takes less expertise, and probably just a bit of trial and error. We talked a bit about pill quantity. It's a really easy place to start, just one pill at a time. Sequence. Now, there are camps that really think that a pill in the mouth before the water is the way to go. And then likewise, there'll be staunch believers that the mouth has to be full of water before you drop the pill in, and there's really no right or wrong, but it's worth trying both for someone who's maybe having some difficulty. Water alternatives are a great consideration. Usually some sort of thicker substance will help individuals feel like it's moving pills down more easily than thin water. There is a instinctive reflex or instinctive posturing of patients to kind of throw their head back as they take a pill. And many of us know from the chin tuck maneuver that probably the better posture, and it's been studied in the specific case of swallowing pills, is more of a chin tuck, and to avoid the head toss back, but in order to appease people who feel maybe like they need that toss back, you can do a little head jostle to loosen up the pill. In addition to some of that orchestration, there are adjunctive products available that can sometimes be useful. And really what these do is take the coordination out of the equation. And so it really helps an individual and their mind think that they're just drinking a liquid instead of coordinating, a pill and a liquid. So there are cups that kind of introduce the pill into the container without actually introducing it into the liquid. And then there are these spouts and straws which do a similar thing without having to have a whole cup on hand. And then finally, there are these great products which can go directly onto pills. So most commonly are lubricants that have been around for some time. These are usually flavored, but not always. And there are several different varieties available. They can be a little bit messy, but some people really like the way they work. And then as far as I know, Medcode is the first variety of a pill wrap that I've seen out there. I put the strawberry on here. I think that's my preferred flavor, but you'll have to try for yourselves. Just take a minute here to summarize that. I hope I have really underscored how common pill dysphagia is, and that we can appreciate that it's probably under-recognized and that we could do a better job of managing our patients suffering with it. And to identify those patients, I think we need to be a little bit more specific in our screening. Maybe the Pill 5 tool will be useful. And I think the best management is going to come from a multidisciplinary approach that involves a pharmacist, the medication prescribers, and this large community of deglutologists that we have here. And I couldn't wrap up without one more clip. This is from a movie about 10 years ago. Let's see.
All right, you. My job gives me access to the most nutritious chemical-free food in the world. I don't want my kid born addicted to high fructose corn syrup.
There is.
Will kill Bruce Lee. Really? Where'd you read that? The Weekly World Dum Dum? All right. This is your folic acid, and this is your prenatal vitamin. You're serious about this? I don't want my baby to have a pinhead. I can't do it. I got it. It's going. I can't swallow it. What is this? Water. That's horrible. No, I can't put it in your butt. Angie, cats can do this. Come on. It's in there. Just try. Just relax. Close your eyes. And do it. Swallow it. Take it. There you go. You did it.
So I think probably that also underscores the importance of a little bit of patience as well. I've included some really useful references that will be available in the slides that you can download for future use. Just want to thank you all for your attention and hopefully have some good questions.
Awesome. Maggie, thank you so much for that presentation and for ending on such a fantastic clip from that movie. We have tons of questions. I don't think we'll have time to get to all of the questions, but I'll get started here. And if there are some that we don't get to and that participants would like the answers to, please feel free to email us and we can direct the questions to you or get the answer somehow back to you. So I'll get started here. One of the first questions that we have here, pill swallowing, it challenges normal deglutition. Is there a standardized methodology that's effective for teaching children how to swallow pills?
Oh, great question. And I don't know of one, but I have read that, some of those the techniques that I mentioned in the strategies are ones that can be used when children are first learning. So trying, a different sequence, a chin down, and then considering using one of those adjunctive products if they're struggling.
When doing an assessment, let's say a bedside, a clinical, with somebody that's complaining of pill dysphagia and they don't have any medications that they need to take at that time, would you advise somebody to swallow something like a Tic Tac to demonstrate their trouble with swallowing pills?
Great question. I would worry about it Tic Tac unless it really did kind of mimic the pill that was giving the individual trouble. I think a Tic Tac's going to be pretty easy. In our clinic, we will tell patients to actually delay taking their medications a little bit so they can bring in the exact ones, that are giving them trouble.
Does a complaint of pill dysphagia warrant an objective assessment? So this question's coming from somebody who works in a skilled nursing facility where video fluoroscopy might not always be available, but should they push for an objective assessment in somebody that has pill dysphagia?
Great question. I think like any patient, it's really the comprehensive gestalt that should drive the choice of an instrumental evaluation. So if it's isolated pill dysphagia without any other warning signs, and it seems that it's something that can be overcome with modifications, and so it doesn't really suggest a structural or a true, say, like neurologic dysfunction, then that might be someone who doesn't need an instrumental evaluation. But if there's someone who also has some solid food complaints and history of, gastroesophageal reflux, or someone with some liquid complaints, a history of stroke, then, I think best judgment would be to do instrumental evaluation.
Okay, excellent. We have a couple questions about the pill 5. The first one here is, does the pill 5 score correlate with oropharyngeal dysphagia diagnoses or only esophageal transit times?
So far, it's only esophageal transit time.
Okay, and is there an age range in terms of the normative scores for the pill 5?
There is. I don't have it offhand, but the other resource that's included is the PDF of the publication. So the age range is on there. I would say that the mean age is probably around 60, with adults, all comers over the age of 18, but the mean age is probably around there.
Excellent. And those documents are all on your toolbars. If you want to download that, you can do that. And we'll also send those documents out after this webinar as well. What is the normal or average length of time that it takes for a pill to pass through the esophagus?
15 seconds.
Okay. Let me scroll through a few more questions here. When doing video fluoroscopy, what you had recommended the 13mm capsules. Do you ever have patients bring their own and try to coat them during the swallow studies?
So yeah, we use a 13mm barium tablet, which we really like because it not only is good for assessing pill dysphagia, but that diameter of 13mm is really a important one, because any sort of area of obstruction is probably clinically important, whether or not they actually have pill dysphagia. To answer that question, I don't actually assess pill dysphagia in the fluoro suite. I don't think our SLPs will have them bring in pills to the fluoro suite per se. It's gonna be a little hard to see and to kind of dip in barium. So generally, we'll do those under endoscopy.
Okay. For patients that have xerostomia or dry mouth, when they're taking pills, sometimes they will coat the pills with olive oil. Are there any sort of contraindications for doing things like that?
No, like something lipophilic like that really shouldn't be a problem. By the time it kind of sits in the stomach and some of all the different bile and hydrochloric acid that's in the stomach, it shouldn't affect the bioavailability at all.
Okay. And along that same line, mixing crushed medications in with a thickened liquid. Any issues with that?
I mean, no issues. I think that probably the question is getting at compared to, say, like just thin liquid or applesauce or something like that. It's just the same issues surrounding a crushed medication may result in an overdosing or an underdosing, and it would be the same whether it was put into a thickened liquid, whether it was put into a thin, or a semi-solid or pudding.
Okay. Any thoughts on using carbonated beverages as a strategy for swallowing pills?
Sure. I mean, I don't know that I've actually seen any literature on it, but it certainly can't hurt. And for dysphagics who do well with some sensory stimuli, that might be a great thing to try.
Okay. All right, I'm just scrolling through. We're getting tons of questions coming in here. I'm just screening out some of them. Here. Do you have any plans to validate the pill 5 on specific patient populations like Parkinson's?
Not that I'm aware of. We're currently looking at pill 5 scores and how they relate to medication adherence, but all comers, not a specific population.
Okay. There's a few people that are sharing their strategies that have been successful with helping patients swallow pills here. Can you remind us what the percentage of Americans that have trouble swallowing pills is?
Over 40.
Over 40%, okay. And somebody commented, do you think that that percentage might be high because children, when they're learning to swallow pills, are usually doing so during a stressful time, like when they're sick and need to take medication? Do you think that contributes to the fear of swallowing pills or difficulty swallowing pills that we learn as a child?
I think that's absolutely possible. I think some adults may carry it with them. That number came from a survey of adults So it doesn't include children, but I think that part of that gross number of adults could be influenced by their experiences as children, for sure.
Excellent. Well, I will stop there. If anybody has additional questions or questions that we didn't have time to get to tonight, please feel free to email us with that. Again, we've recorded tonight's presentation, so if you want to go back and watch any of the parts that you may have missed, you're welcome to do that. We'll have that up within the next week on our website. And Maggie, again, thank you so much for your time tonight. I'm going to turn it back over to Ed.
Maggie, I have a question. So on slide 6, you said that 45% of the pills are consumed by people in the U.S. So while you were talking, I asked Dr. Kuhn, the population of the U.S. compared to the world, it was under 5%. What do you attribute this enormous amount of pill taking to in the U.S.?
Yeah, that's a great question, and I don't really know the epidemiology of that, why that would be so so disproportional, unless that figure also is one of it could of US produced pharmaceuticals, and 45% of them are consumed locally at home. But yeah, I don't really have an answer for that discrepancy.
Okay. I want to thank you for volunteering your time tonight. There were a lot of not just questions that came in, but comments about how amazing your presentation was tonight. So, so thank you for joining us. And then I just have a few small housekeeping items that I'm going to go over. So,
Thank you.
Okay, maybe I'll see you in Las Vegas in February, maybe not.
Fingers crossed.
Yep.
Be well, Ed.
Okay. So a few housekeeping items. If you had a question that wasn't answered, please email us at info@nfosd.com. We'll try to get you an answer. And you will get an email. It should be within an hour. It's one page, 9 or 10 questions, takes less than 2 minutes to fill out, but it's really looking for feedback on not just this webinar, but on future webinars and what would be helpful. Lastly, I would like to thank Elizabeth Lipton, our executive director, for organizing this event. I hope that all of you in the US and around the world are learning to manage within the pandemic. And with that, I am going to sign us off for this evening. So thank you for joining us, and see you hopefully at our next webinar. Good night, everyone.